morning, thank you for coming. I wanted to introduce our speaker. This is Dr. Pasternak. He is Louisiana's only adolescent trained specialist. So he's here for the third time.
I think so.
Generously traveling up here from New Orleans to help make sure we get some training in adolescent medicine. And so I'm very happy that he's here. He's helping also look into our adolescent rotation. And
Sure. Good morning. I didn't know Lauren was going to use that moniker of the only fellowship-trained adolescent medicine specialist in the state, but that's going to change actually in July. There's going to be a colleague of mine coming down from Cincinnati to go to Our Lady of the Lake in Baton Rouge. So at least have some camaraderie. So I'm going to talk about adolescent contraception. So good morning. Ryan Pasternak, LSU Adolescent Medicine in New Orleans. We're going to talk about adolescent contraception. It's very unlikely that I get through all these slides this morning. I know that. Hopefully you guys get this stuff pushed out to you or have access to it. But I think the first half we'll try and talk about or maybe even go back to. If you can't hear me, let me know. And there's a few questions in here, so since you guys are spread out in this large auditorium, you may just have to yell it out, all right? So this is part of our REAL, or Reproductive Education and Advocacy Louisiana program. It's a program that's partially funded by the David and Lucille Packard Foundation to advance reproductive health throughout the state of Louisiana. And there's our mission. 3 main objectives. That first one is just really understanding why contraception is an important issue to address as pediatricians, discussing some of the elements of medical and sexual history for contraception initiation, and then going through a list of methods. These are most of the methods that you would be prescribing or advising patients to use. I'm not going to go in depth on like rhythm or thermoregulation method that aren't quite as effective for adolescents. Those are methods of contraception, right? No relationships with industry. I am going to occasionally use brand names to sort of clarify when we're talking about different methods because there are several under each class, and then discussing off-label use, particularly of IUDs, because many of the IUDs, I'll throw out a brand name now, like Mirena, when they were first went through FDA approval, they didn't study them in persons under 18 explicitly. So they're not explicitly approved for those persons, even though our guidelines say that they're safe and effective to be used in adolescents and persons under 18. So I think the first question is who and why. So are patients having sex? Yeah? No? Adolescents? Maybe? Anybody treating the STIs in your clinics? So 97% of Americans do have sex. 3% don't. 95% have had sex before marriage, and that's been since the 1940s. So our grandparents lied to us for the most part about this, but that's all right. They can have their cake and eat it too a little bit. But 80% have had sex by age 20. So most of us are taking care of patients. If you're med-peds, you're certainly taking care of patients into the 20s. So the vast majority of those patients will have had sex. And then 50%, I say, by the junior year fall dance. So this is a little bit of a bump up. So about age 16 and a half, 16.4 years, used to be about the average age of onset of sexual intercourse in the United States. Now it's about 16.7 to about 17 years. It's not really a huge statistically significant difference, but it's a little bit of a delay. So I used to be able to say the summer between sophomore and junior year. Now it's like junior year homecoming. That's about your 50% there. So our patients are having sex. How long after initiation of sexual intercourse or being sexually active does the average adolescent woman in the U.S. wait to make their first family planning or reproductive health visit? Any guesses? 14 months. So gestation's how long? 9. So about 5 months longer, so a little late. And then, particularly for us as pediatricians and med-peds folks, there's not enough OBGYNs in the country to really do all this work. If you really look at the number of adolescents that are sexually active or engaging in types of sexual activity, referring them all to OBGYN really isn't going to be effective. There's just not enough of them, and many of them aren't really well trained. My colleagues will say this as well, and OBGYN will say this as well, to deal with adolescent patients. Outside referrals also, we know, add delays in care, so whatever we can do and add into our primary care setting and primary care practice
benefits our patients. And then engaging patients about sexual health is part of pediatrics. It's really part of what we're supposed to be doing and trained in. And then the teen pregnancy rate is declining, right? So some folks will say that this isn't really necessary. Teen pregnancy rates are dropping precipitously throughout the US, which is true to some extent. This goes up through 2011, but you can see that we peaked during my adolescence actually in the 80s and then came down since then. There's a little bump there. You see that little bump on where's the little pointer on this thing? So this is Bush administration abstinence-only implementation. I guess that stuff got implemented right around here, and then you started to maybe this was an effect from that, we're not quite sure. But then we started to see a decline again. About now, it used to be about 86%, now over 90% of this decline is attributed to better access to contraception for young persons. So that's the main driver of this decrease. But, oh man, didn't quite transfer. But you can still see. So the first one's the United States, the second one's the United Kingdom. So we're still doing much, much worse than our comrades in other places, in other countries. And then I could throw a similar chart up here that was states in the US, and we'll see that most of the southern states are also having much worse outcomes in terms of unplanned and teen pregnancies, STIs, and those sorts of things. So I don't think I need to beat Louisiana over the head or anything anymore about that, but we know Louisiana, Mississippi, Alabama, we sort of always see those rates are much higher. The value here, I don't know why it didn't come over, but it was 27.1 per 1,000 females aged 15 to 19, so 27.1 births in that age group. So we're not doing a really good job keeping up. So how do we talk to patients? And I think this is, for me, this is the first and most important part of the whole talk. How do you engage patients and start to have that conversation with them? Because if you can't talk about it, then you're probably not going to do it. And this is true for anything in medicine. If we don't sort of know what the next step is, we don't know what to say to a patient, probably not going to say anything and maybe transfer them to another provider or not. The patients aren't going to get care. So one way to do it is to use what's called the PATH questions, the pregnancy, attitude, timing, and how questions. This can be used with patients of any age in any sort of state. So do you think you might like to have more? They've already had children, but do you think you might like to have children at some point? And I'll ask this of parents too. Do you think you might like to have grandchildren at some point? Almost universally, the parents of my patients will say they want grandkids one day. And then I said, well, when do you imagine being a grandparent? Oh, not for another 15, 20 years. I'm like, okay, so you expect your child to have sex within 15 to 20 years. And then that kind of freaks them out. They sort of really want to have grandkids, but they still don't want their kid to have sex. So I'll ask this question of patients, though. Do you think you might like to have children at some point? If they say yes, if they say no, great. Now we need to talk, skip to question 3, but if they say yes, well, when? About how long from now? Most of my patients, 14, 15, 16-year-olds, are telling me mid to late 20s, they think. Some of them will tell me when they're 18 or 19. And then how important is it to you to prevent pregnancy until that time? So a really easy, quick way to sort of get into this. In one visit, you may just kind of put this in and not do in-depth counseling. At other visits, you may add that counseling piece, but at least knowing this and having a plan. So we're going to use Angela as our case throughout the rest of the talk today. So she's 16. She comes in to make an appointment to go on birth control. You do those PATH questions, and she indicates she wants to have kids in her 20s. She says it's kind of important for her to prevent pregnancy until then. Her form indicates that she uses condoms most of the time, and other information you might need from her. What else do you want to know from her? Anything? So this is what we used to do on the left-hand side, the old school guidelines for what you want to do. So complete history and physical and family medical history and all this other stuff. Rule out any and all risks and contraindications to contraception. Complete exam. Again, it looks like the formatting didn't carry over. Now we think about a more streamlined approach to this. So monitoring blood pressure and weight, doing a brief medical and menstrual history. I think taking a menstrual history is important. I don't like to start patients on contraceptive methods and then find out later in retrospect that they probably had some menstrual disorder. I think that happens a lot, unfortunately. last time they had sex, ruling out absolute contraindications, and you'll see an asterisk there, and you should see them later on, and then providing condoms and advanced emergency contraception regardless of the situation, unless the patient's already pregnant, and then checking for a negative UPT, and then starting contraception that day. So the things in bold would be the things that are absolutely key. So you don't necessarily need to know when the patient had menarche, but you definitely need to know when their last period was. Personal history of significant clotting, so PE, DVT, that sort of stuff. Personal or family history of clotting that you might need to work the patient up. And in our more complex contraception clinic, we have a whole group of patients that sort of fall into that category, and we work with hematology on them. But I do think that cycle length and regularity, probably should have bolded that. Have a lot of young women that maybe have PCOS, other things. If they get started on a method of contraception, particularly something like Depo or something long-acting, and we don't know that beforehand, when they come off, they may have continued menstrual dysfunction, they may have fertility concerns. Oftentimes, the contraception gets attributed to the contraception, which is likely inaccurate in most cases. So we'd like to treat those disorders in advance. So Angela's a little unsure for medical history, but she doesn't think anyone in her family has had blood clots, and she's not had any of her own. She has pretty normal menstrual function, normal duration, normal frequency, that sort of stuff. Who's heard of a HEDS assessment? Somebody's got to raise their hand. All right, so a HEDS assessment. So now we think more of the SHEDS assessment. So starting with strengths and spirituality, I usually put it at the beginning. We used to add it at the end, but I think it's nice to get that information at the beginning because you might need to go back and rely on that or reflect on that later if the patient does have issues that they're struggling with. Where can you sort of build support, or where do they get support already? Spirituality for some patients is a really key area of support. For others, it may be an area of conflict. But knowing that up front, and then obviously all these other sections. We're going to focus on the sexual health section today, but I think for our adolescent visits, this is one of the ways that we frame our screening and our conversation with patients. So taking a sexual health history, so we already talked about the PATH questions as a way to get to childbearing plans and get the patient to think about that, and you to think about that in terms of the way you're going to provide your counseling. Types of sex. So we pretty consistently ask about vaginal, oral, and anal sex. Made a nice little template in EPIC. Actually, I think now you might be able to pull it in there, but a nice little template for that in EPIC, just yes, no's, and follow-up questions. Condoms and contraception, and then genders of partners and numbers of partners, pregnancy history, history of STIs, sexual orientation and gender identity. That's maybe the next talk I come up and give and talk about. It's important, but it may not be absolutely essential in the context of every single visit. Age at first sex, and then some of these other things about survival or unwanted sex, transactional intercourse, but again, focusing on some of those bold things for this visit. So Angela's had vaginal sex 3 times with her current boyfriend. She used condoms 2 of those 3 times. So what did she do well? She used condoms the majority of the time. But how do you focus on getting that to be 3 of 3 if possible? She came in to discuss birth control methods, so she's here seeking care for something that she needs. And giving positive reinforcement, I think, for those things is really important. Ideal use, though, is dual use. Does anybody know what dual use is when I say that? So dual use is the idea that we're going to use condoms as backup to a more effective method of contraception. This is what, in many other countries in the world, is thought of as safe sex. So when we think about safe sex in the US, typically we are talking, I think that moniker really has come to mean using condoms and not getting HIV. That's, that term really came to light in the late 80s, 90s, beginning of the HIV epidemic. Safe sex, don't get HIV, use condoms. In other places of the world, though, it's about preventing unwanted or unplanned pregnancy and STI prevention, and the best way to do that is through dual use. So what else? What else do we need to know? So we can work on her condom use. We can. She came in to talk about birth control methods. The other thing we need to know, though, is has she had unprotected sex in the last 5 days? Was that time when she didn't use condoms in the last 5 days? Because then we need to talk about emergency contraception, which is a form of contraception, and actually probably the thing we should be prescribing or providing most often to our patients, because the AP guidelines say that we should be providing advanced prescription before patients need it, and potentially before they become sexually active, because the shelf life is 2 to 3 years. So if she has not had unprotected sex in the last 5 days,
and it's been more than 5 days, so 14 days or longer especially, then a UPT, give her an advanced prescription for emergency contraception. If she has had unprotected sex in the last 5 days, then we need to offer her emergency contraception. Anyone ever prescribed or given prescription or referred a patient for EC, ER? Nobody. All right, so we're going to talk about that now. This graphic comes from the website bedsider.org. So it's an easy place to go online and show some of the stuff to patients, but you can also log in as providers and tear off packs of these handouts and things. This one, I think this might be the up-to-date one. One of the other ones I'll show you is a little bit out of date. So emergency contraception, 3 major methods that are available to our patients. So the copper IUD is available and useful as a method of emergency contraception. Those patients that are able to get that and use that method then have a really effective method of long-term contraception. It's almost 100% effective. You want to use it within 5 days, and it maintains its effectiveness during that time frame. Ella, ulipristal acetate, is prescription only, but it's also very effective and maintains its effectiveness over that 5 days much better than the levonorgestrel containing products like Plan B, One Step, and the other generics. But you do want to use it as soon as possible. So it works by delaying or preventing ovulation, and so the sooner you take it, the more effective it is. And then the last one is Plan B One Step. Again, you want to take this as soon as possible. In the first 12 to 24 hours, it's most effective. Ella is less effective for women closer to 200 pounds, over about 195 pounds. We know that for the levonorgestrel containing products, you may start to get decreased to minimal or no effectiveness once you go above BMIs beyond 25 or so. So we still provide it to patients. Oftentimes Ella may not be available. We're doing a little secret shopper study of pharmacies around New Orleans and eventually around Louisiana to sort of look at that. Because we get different answers, whether you're the doctor or the patient calling and asking about that. I think providing some method is better than not providing any. So those are all key. Again, the AAP guidelines for emergency contraception say advanced prescription. So we want patients to have this method in a dresser drawer before they need it, so that if they do need it, then they can get it in that first 12 to 24 hours. They don't feel like they have to go to the pharmacy. Some of these methods can be $30, $40, $50 depending on the pharmacy. You can use GoodRx or other apps to help figure that out. But we want patients to have it available beforehand. So I often have that conversation with patients, but I also often have that conversation with parents and say, look, I'm following guidelines and providing the prescription. Child may not even be having sex right now, but the shelf life of this is 2 to 3 years. She's 15, and she's going to be 17 or 18 by the time this expires. Hopefully they don't need it. If a friend needs it, it's over the counter for Plan B. They can obtain it anyway. Boys can get it. There's no real restrictions anymore on who can provide this or who can get it. So boyfriends can get it too. So starting contraception after using a levonorgestrel containing emergency contraception, so that would be the last one here. So you can start any of these methods immediately after Plan B One Step. All methods, you want to abstain or use backup protection for the first 7 days. It's just good practice. Gets a little trickier, so I'm going to just say this and then you guys can look at the slide, but ulipristal acetate is a progestin agonist antagonist. And so starting those hormonal methods that contain progestin, it's a little trickier with ulipristal acetate. You may actually be decreasing the effectiveness of that as emergency contraception while also starting the patient on a longer term method. So, in conversations about this professionally, colleagues, if we feel like we need to provide the EC, but we feel like there's a relatively low risk of the patient becoming pregnant, then maybe we'll give both and start them both at the same time, just to make sure that the patient is on some method of long-term contraception. If we're really concerned, then we'll try and get the patient to come in, or we'll make them wait. And there's some evidence that they may need to wait a little bit longer or use backup protection for more than 7 days. That started to come out. So she says the last time she had sex was 2 weeks ago. Her UPT is negative. Do you need to do a pelvic exam or PAP on her before you start birth control? Anybody? No. Right. So you don't need to do a pelvic exam. There's nothing that you're going to see on the exam, with the exception of if you're going to place an IUD, but you're going to do that as part of the exam. So you can either tie those two things together or do the exam and then make a decision about
placing the IUD then. But all cervical cytology guidelines, looks like it disappeared under there. Age what? When do you start doing Pap screens? 21, right? All right, so only patients that I have that are exceptions to that generally are my patients that are transplant patients or HIV patients that are immunosuppressed. You may start earlier if they've been sexually active. All right, so Angela says there's, you tell her there's lots of methods available to her and that you think that you guys can work together to find a method, so using that shared decision-making model, and then other questions you want to ask before starting. She tells you she wants to know which method's going to work best, last longest, and she definitely doesn't want to have children for 5 to 10 years. So what might be, in your head, what might be a really nice method for her? Say it again? IUD, okay. So IUD might be one. So we know all methods aren't equal. So I was talking about this last night at dinner with Lauren and Dr. Bikini and Randall and Tierney that we used to sort of use this deck of cards approach and sort of toss out all the options of birth control and then sort of let the patient pick which one they wanted. We don't do that in other parts of medicine, so that's probably not effective. But we also don't want to sort of just pick the method that we want for the patient based on our own sort of personal biases. So some shared decision making, but also recommending and recognizing that not everything works the same and not everything is as effective. And take that patient's goals, 5 to 10 years for her before wanting to have kids, and marry that up with the other factors. So that top line is all your stuff that's really super effective. So the implant, various IUD methods, and then sterilization. The implant, incidentally, is a little bit more effective than having your tubes tied. One of my OBGYN colleagues explained that to me. Sometimes you might clamp a ligament instead of the fallopian tube, and if you don't clip it out and send it to pathology to look for that double lumen to confirm that on both sides you got the fallopian tube, you may have a patent tube. And so the implant works a little better than that. So she always clips hers out. And then the middle row, those methods are moderately effective. And then the last row, that cork, they changed, this is the one that says a little out of date. They changed that cork to a party popper in the new graphic of this, but that's pulling out. It doesn't work so well, kind of like the party poppers. They go off when you don't expect. Condoms, they're needed for STI protection, but you want to use them with any other method. And so actually, if you look, this is your chance of getting pregnant. So over the course of a year, how many in 100 women? So less than 1. They couldn't make a half a person here, but this is 0.1. Less than 1 in 100 women over a year. You got about 6 to 9 for that middle row, and then 12 to 24 for that last one. So we're going to talk about LARCs, or long-acting reversible contraceptives. So these are the most effective methods, or more than 99% effective. They don't contain any estrogen, so if your patients where estrogen is a contraindication, this is really nice. And they have long-term protection lasting between 3 to 12 years. You have a rapid return to fertility when you discontinue the method, which is really nice. Usually within 2 weeks, patients start having regular ovulation cycles, and they're the most cost-effective over time by far if you compare it to a pack of pills every month in terms of cost. So the Etonogestrel contraceptive implant, anybody trained or placed these before? Yeah, so next one on. So we're working to make sure that all of our residents actually get trained. The ability to do this is actually working its way up in terms of the guidelines and expectations for being boarded in pediatrics. So it's a small rod. It's very effective, 3 years. Failure rates, like I said, 0.1%. It's very cost effective, and it inhibits ovulation. So side effects, the most important thing to explain to your patients is that this is going to cause them irregular bleeding. So light spotting or bleeding kind of comes and goes, much like Depo, but it tends to last a bit longer. So if I am telling patients on Depo-Provera that it's going to last 3 to 6 months potentially before that fades away, and patients are typically anovulatory and don't have bleeding. For this, I'm saying 6 to 9 or even 12 months to anticipate that. It may improve acne in some patients. Concerns may be weight gain. The weight gain, the studies so far show that that's pretty minimal. The irregular bleeding patterns that we mentioned, and then the insertion and removal requires office visits, so coming back for that. And the removal is not as easy as the insertion, I'll say that. But I think that having providers, it's a nice procedure to do if you like procedures, and having providers in the office. One of my OBGYN colleagues as well, she actually is like the default removal person for all of her OBGYN colleagues, so all of them replace them, but they all send them to her to take them out, just because she has a clinic where she has the time and does that. So the initial expense, so in Louisiana, so oftentimes for all these LARC methods, folks are a little bit reticent to start them or have them in their office because they're afraid they're not going to get paid for it. But Louisiana Medicaid in particular, they sent out letters 2 years ago, I think, maybe 3 years ago, and basically just said, like, please, 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 stock these methods in your office. We're going to pay for them. They peg the reimbursement at the current cost of the method, so you're not going to make money on the device. You're going to get paid on the insertion, but you're not going to lose money either. And so we end up having these conversations with our business folks and stuff who don't want to order them. And I say, look, just buy like 1 or 2 of each and let me sort of prove it to you. Now the hospital, Children's Hospital, just stocks them for us, no problem, because they've seen that they can get paid. Levonorgestrel containing IUD, so we'll start with that one and then we'll do copper. So the 20 microgram one, so we have a few. Some last 3 years, that one is a little less than 20. And then 5 to 7 years for this. So this would be what you would think of as Mirena or the generic versions of that. We know it lasts actually up to 7 years. It's a progestin-only method. Primary mechanism is fertilization inhibition, cervical mucus thickening, and sperm inhibition. 7-year failure rate, again, very low. So 7-year failure rate, 0.5 to 1.1 pregnancies per 100 women, which is incredibly low. And then the copper IUD. So this uses copper ions, produces somewhat of an inflammatory response, and fertilization inhibition, reducing sperm motility. Again, 12-year failure rate for this one, 0.7 to 2.2 pregnancies. All right, so common myths about this, that they can't be used by teens. That's not true, right? We have AAP and ACOG guidelines both saying that these methods are safe and effective, and some of the most safe over the period of time that they work, and most effective for younger persons. Nulliparous women can use them. Again, Mirena, it's an off-label use of that because they did not study it in persons under 18, but we know that it works well. But many of the newer versions and the generic versions of that same device, they did go ahead and get that recommendation for nulliparous women. Can it be used by women that have had an ectopic? Yes. And can it be used by women with multiple partners? Yes. Can it be used by women with a history of STI and PID? Yes. You're not going to place an IUD if someone has an active cervicitis or if they have active PID. And PID, you're going to treat it and you're going to wait 3 months before you place an IUD, but just having had a history is not a contraindication. And do you need to remove it if they have PID to provide treatment? No, you leave it in place and you treat PID the way you normally would. In some respects, it reduces the risk of PID and reduces the risk of ectopic and those sorts of things because of that cervical mucus thickening that it also provides. Perforation risk is very low, and expulsion, the data is variable. It's pretty low. We used to think that 15 to 20% of nulliparous women had expulsions, but there's been a subsequent study that showed actually the expulsion rate in nulliparous women is lower than parous women. So, even if it was coming out 20% of the time, it means it stays in 80% of the time. So which one's the best choice? I think that's really dependent on the patient and their factors. We tend to use the copper IUD in patients that, for one reason or another, don't want or can't have progestin or other hormones. So maybe my trans male patients that need an IUD for some reason, or oftentimes we've got a large group of lupus patients that nephrology refers us. If they have positive antiphospholipid antibodies, or we don't know that if they have positive antiphospholipid antibodies and they're hypocoagulable, then we use the copper IUD as a method. That's really the only method that you can use for effective contraception in those patients. Levonorgestrel IUD, are they okay with the amenorrhea and the history? Do they have a history of dysmenorrhea? Menorrhagia, there's a specific indication for heavy menstrual bleeding for these methods. And then you don't want to use the copper IUD if somebody has Wilson's disease, right? It's like the one thing. So combined methods. So combined hormonal contraception, or CHC. So this is everything: pills, patch, and rings. So the way I think about this and counsel on this, the risks and benefits are very similar across these different methods. It's just a different way of getting the medication into the patient's body. So a different delivery device or delivery system. And I think
I tend to frame things that way about the delivery system, because deciding on the delivery system is really, for the most part, what the patient is having to determine for themselves what's going to work for them. They work by ovulation inhibition, suppressing LH and FSH, and then progesterone also thickens the cervical mucus again and inhibits capacitation of sperm. So who's seen the CDC medical eligibility, or we call it the MEC criteria for contraceptive use? Anybody? So there's an app for this. I would highly recommend downloading this app and being able to use it. In all of our clinics, we tend to have you'll see the sort of paper form laminated, several copies, and flip it back and forth and look, because we'll have a patient that had a lupus and a renal transplant and a history of seizures, and we're trying to figure out what the best methods are for those patients. But generally, using that app is pretty effective. You can go through it by condition, or you can go through it by method and look up. So there's 4 categories. So category 1, which on the chart is a darker green, no restriction, the method can be used. Category 2, advantages generally outweigh theoretical or proven risks. 3, theoretical or proven risks generally outweigh the advantages. And then 4, unacceptable health risk, you shouldn't be using that method. So this is just one page. I don't expect you guys to be able to read it. I just want you to see the colors. The vast majority of the charts are green. There's very few things that aren't. If you look, this section here, this is like current breast cancer. All right, or so that actually this line, the 4s, is current, and this is past, but within the last 5 years. So that makes sense. Distorted uterine cavity. Right, so those are all sort of severe hepatobiliary disease is on there, or hepatic cancer. But most of the stuff is green. So category 4, so what are absolute contraindications for combined hormonal contraceptives? Again, current breast cancer, cirrhosis, but things that we would think about for most of our adolescent patients: acute DVT, pulmonary embolism, documented thrombogenic mutations, which you're either investigating, in advance, you're getting family history, that sort of stuff, or migraine headache with aura. And I just had this patient on Wednesday that I had to not give a combined method to, and that's what they really wanted. Hypertension, severe hypertension, or hypertension with vascular disease. Again, some of these things are typically more adult related. Are they postpartum? Are they over 35 and they smoke more than 3/4 of a pack of cigarettes a day? Complicated solid organ transplant. And then lupus, I mentioned that, with unknown or positive antiphospholipid antibodies. And then this is category 3, relative contraindications. So they're less than 1 month postpartum and breastfeeding. Again, they've had a history of DVT, but a low risk for recurrence. They're postpartum with VTE risk. And then some of these drugs. So most of these drugs are going to decrease the effectiveness of your combined hormonal contraceptives. Some of the anti-seizure, anti-epileptic drugs, actually the combined hormonal contraceptive is going to decrease the effectiveness of that. And in those cases, I really encourage long-acting methods, or maybe something like Depo-Provera, because sometimes neurology will be tempted to bump up the dose of the anti-epileptic medication, but then what happens in your placebo week when you're not actually getting the hormones, then their dose of AEDs is actually going to go up and you're going to start to see a lot of side effects. So try and manage that. But generally, these are actually negatively impacting the effectiveness of your birth control. So estrogen-related side effects. So it's rare that patients have these serious estrogen-related side effects related to clotting, but we always talk about them when we use this mnemonic ACHES. I go through it with every single patient, even for many of the more complex patients that are maybe going to start a progestin-only method. I'll go through this. So they should call 911 or go to the ER, see somebody immediately if they have any of these. So severe abdominal pain or cramping, worst stomach pain of your life. Severe chest pain with shortness of breath, or that elephant on your chest kind of feeling. So it could be a PE or an MI. Headaches, severe headaches, worst headache of your life, or any headache with visual changes. Again, that could be retinal, the next one's retinal, but that could be cerebral artery. And then eye or visual changes, vision loss, and severe leg pain or swelling, typically DVT type symptoms, right?
So I'll go through that, I'll write it on the chart that I discussed the aches. And then progestin-related side effects, so edema, abdominal bloating, anxiety, irritability, and depressive symptoms. Oftentimes I'll hear people say, well, most of my adolescent patients, they've got some depression or they're a little anxious. I really don't want to start any of these methods because I'm worried that's going to make it worse. Remember that the reason that we're all, well, at least OB and those of us that deal with patients that are or were recently pregnant, we always have to screen for postpartum depression and depression in pregnancies, that the risk for depression in the context of pregnancy is very high, way higher than the risk for depression in the context of using these medications. But you want to screen for those things. Myalgia, I haven't ever had a patient with that, but and then menstrual irregularities, we expect that with progestin. Effectiveness, again, for combined hormonal methods, perfect use, about 0.3%. Typical adult use, though, is 8% failure rate, and then typical adolescent use ranges between 5 to 25%, looking at different studies. It's mostly just adherence. I used, when I was taking Lipitor for a while, I used a med reminder app called Mango Health. It was really good. It buzzed me whenever I was supposed to take it. It gave me prizes for being consistent about it. And I thought I was awesome at taking my Lipitor. And about 67%. I took that medication once a day about 67% of the time, effectively. So adolescents aren't necessarily great at maintaining this. Other benefits, it does improve acne and hirsutism. We use combined hormonal methods with our patients with polycystic ovarian syndrome a lot. So who knows how it improves acne and hirsutism? What happens? It's very brief. No? So you get an increase, you get a rise. You can see this for patients where we have to do regular labs. You'll see this, a rise in sex hormone binding globulin. That sex hormone binding globulin is going to bind up free testosterone. You're going to get less of that bioavailable testosterone. So that's how it usually improves that. Some of the progestins can cause some acne though too. Improving anemia, just typically through decreased menstrual blood flow loss, and then other menstrual-related health effects. Reduction in ectopic pregnancy and PID, those two things we know are connected, again, through cervical mucus thickening and decreasing the risk of PID. So remembering that while we screen in this country for chlamydia and gonorrhea and have really clear screening recommendations for chlamydia and gonorrhea in young women, the reason that we're screening for that is to really prevent PID. It's kind of ridiculous, huh? All right, so oral contraceptive options. You've got a wide range in terms of your estradiol formulation. Well, we typically think about methods with 35 micrograms or less, and then there's 8 types of progestins. So again, the methods that we're usually prescribing, right, 30 to 35 micrograms of ethanol estradiol down to 20. I'm rarely using low estrogen, but you might use that in some patients on occasion. Those are all considered low dose. 50 is usually unacceptably high, but we usually use that for heavy bleeding. So knowing that the lower you go with these methods in terms of the estrogen dose, the more breakthrough bleeding you're going to have, and potentially the more bone mineral density impact. So thinking about that, but you're also going to have less estrogen-related side effects, so for patients that are particularly sensitive. And then monophasic versus multiphasic, there's no real difference in tolerance or continuation rates for either of these methods. I'm not convinced, in most of the more recent studies don't really show that there's really a benefit to multiphasic methods, but they may have a little bit less breakthrough bleeding. So again, if patients have that as a concern, you might switch them to this. And I try and keep patients on these methods for at least 3 months because most of the side effects are transient and they last less than 3 months, a month and a half to 2 months. So if they can stay on, it's kind of like formula. I don't take care of babies with formula anymore, but watching my colleagues do it, try and avoid like formula switching again and again and again with babies if you can. I think about it the same way. Taking the pill at the same time every day, so figuring out how to do that. There's lots of apps for that, and then counseling them on how to manage missed or late pills. Lots of different cycling. So traditional birth control pills, when we think about it, we think about a 21 7-day cycle. 3 weeks of active medication, 1 week of placebo or inactive medication. But there's lots of different ways to take these methods, and you don't have to take it that way. You can have some pills that already come pre-packaged with a shortened pill-free interval, down to about up to 4 days. Is that short? That pill-free interval that just means having less menstrual bleeding and that sort of stuff, to no pill-free interval. So you can use methods that are prepackaged as continuous, or you can bicycle or tricycle patients. We're oftentimes doing that in the context of heavy menstrual bleeding. And there's no real negative health outcome to doing that. They may have, with a continuous or bicycling or tricycling, they, again, may have some increased breakthrough bleeding, but in terms of their fertility and those sorts of things, there's no negative impact. There may be positive impacts long term. So are these the best choices? It depends, right? They're safe, effective, quick return to fertility. You got to maintain daily adherence, and then you've got to maintain, deal with those estrogen-related side effects sometimes, and then other meds that induce cytochrome P450 like AUDs. So providing more than one cycle of birth control pill at that first visit certainly increases continuation. And this effect is greatest for those under age 18. So at least giving 7 pill packs. So that's, giving their first dose plus maybe 6 refills. They had a higher 6-month continuation rate than those just getting 3 cycles. It's just because they have to come in more. I think it's reasonable to give them these after you've done the counseling and started them, bring them in at 6 months and do labs and follow up, but tell them if they have a problem or if they're having significant side effects or they're concerned about stopping the medication, then to come in sooner. Progestin-only contraceptives, so where it was, Tierney, I was going to ask you if I could say this. So Tierney told a story last night about what her your dad's an OBGYN? Yeah. What he called the rhythm method, or what he called women that use the rhythm method, and that was mom. And I think about that the same way for progestin-only methods. I think of these methods as being a really good way to get pregnant, but taking something. So the reason is these have a very short half-life, and you got to take it exactly at the same time, pretty much within an hour or so every day to really be effective. It thickens the cervical mucus. That's really its only mechanism of action, and timing is crucial. But for some patients that can't or don't want to use the other methods and need something and can't use estrogen, occasionally we use this. Usually we're using progestin-only as a way to induce withdrawal bleed, or hopefully induce withdrawal bleed. So Angela says she doesn't think she can remember to take this every day, so what else can you offer her? So other combined methods, vaginal ring. Anybody ever prescribed this? So this method, if I could sort of wave a magic wand of all 3 combined hormonal methods, I think this method is probably my favorite, because it's just, no pun intended, it's super flexible in the way that you're able to use it, and in the way that you can manage things with a patient, because you can leave it in for 3 weeks and take it out for 1, or you can leave it in for 4 weeks, take it out and put a new one right in right away. They can leave it in during intercourse or take it out during intercourse. There's just a lot of you've got a lot of flexibility. So same medications, estrogen, progestin, like the pill, and then as I mentioned, you've got lots of ways to deal with it. It actually lasts over 4 weeks, lasts about 5 weeks. So the nice thing about that is the patient might just have to remember 2 days out of a month. They might remember it by date, or just 1 day or date out of the month. Like, the 13th of every month, I'm going to take out my ring and I'm going to put in a new ring. Advantages, again, safe, effective, low dose, all these things that we've kind of talked about. There may be some increased vaginal wetness and discharge that may be an advantage or a disadvantage. Partners may feel it during sex. In these studies, the vast majority of partners did not feel it. If they did, they, quote, did not find it unpleasurable. And one of the books, and you guys might look into buying this for the adolescent rotation, that I recommend is, there's a big book called Managing Contraception, or Contraceptive Technology, but the little mini books, Managing Contraception, are really good. They go in detail, risks, benefits, side effects for every single method. It's got counseling guidelines and that sort of stuff, and it's got an abbreviated version of the MEC in the back. Angela likes the idea of the ring, but she doesn't want to touch her own vagina. That's the real reason most of my patients won't use this method, and so we want to talk about other options. So the patch. This is probably my least favorite of the 3, although it's maybe better than pills in terms of adherence. So estrogen, progesterone, just like the pill, 3 weeks on, 1 week off. You can now use this one continuously. There's about 9 days of medication in each patch. It's pretty forgiving of delayed reapplication. There is a higher detachment rate, up to 35% in teens. The main thing is them putting it on, not putting it on in a place where there's like a bra line or a panty line or something like that, underwear line, belt line, so anything like that that's going to sort of rub can be an issue. Higher failure rate among women who weigh more than 198 pounds, and then increased amounts of estrogen may increase clot risk, but still very low, definitely lower than pregnancy. So this was used to talk about 2 different things, but I'm mostly going to show the fact that, and it's similar with it's lower, but similar with the ring. Nice sort of flat line right here, and then you take it off and it drops, right? As opposed to pills, where you're getting these peaks and valleys, and you're trying to always maintain. This is 20 picograms per milliliter blood concentration. So you're always trying to stay above that to be effective, seeing that this area under the curve is likely higher for the pill or for the patch than the pill. So that was one of the concerns about thromboembolism, but the studies are sort of still variable on this. But these peaks and valleys tend to be some of the things that cause some of the side effects and problems with the pill. And again, the ring would probably be right around in here. All right, we're going to skip some of this stuff. So counseling issues, so this is just looking at thromboembolism and combining risk in the general population, combine oral contraceptive users, and then pregnancy. So pregnancy is, again, much higher. Counseling issues, again, clean, dry skin, no patch during the 4th week, apply a new patch after day 7. So that's one of the things that sometimes people get confused about with pills and with a patch or the ring, is they're going to start bleeding in that interval when they're not getting hormone, but they may not stop bleeding until after restarting the hormonal method, right? So they may put on a new patch or insert a new ring or start a new pack of pills and they're still having bleeding. That's okay. It's also oftentimes anticipated, particularly depending on how long they used to bleed before using a method. And then missed or late patches using a backup method if it's been on more than 9 days or off more than a week or falls off for more than 24 hours. All right, so we're gonna try and go through this because I gotta wrap up. Extended hormonal contraception, so I kind of mentioned this. This is just continuous use of all these methods. So Angela says she's heard about the patch. She's worried somebody at school might see it. My very first patient I ever prescribed the patch to, I was so excited. She was so excited. She was like, I've got this method that I don't have to remember every day, and my mom's not going to know. She's not going to see my pack of pills sitting around. This was before the ring came out. And she put it on her shoulder blade, which is a good place. And people should move it every week. New patch, take it off here, put it here, take it off there, put it here. Macarena, sort of. But she had it on her shoulder blade and went to take a shower and came out of the shower and had her towel wrapped around her and walked out of the bathroom to her bedroom, and her mom was like, and her mom could clearly see this big giant square Band-Aid on her back. And was like, did you hurt yourself? What is that? Day 1. And so then, we had to have a subsequent conversation after all that confidential care. Anyway, but then that same summer was the Olympics, Summer Olympics, and where was that Summer Olympics? I'm trying to remember. I feel like it was in the U.S. and not Atlanta. Anyway, and the women's volleyball team, I can't remember their names, but the 2 women that were the champions, they both had their ortho-ever patches clearly displayed around their uniforms. All right, so injectable methods. So Medroxyprogesterone acetate, or commonly referred to as Depo-Provera. So this is a progestin-only method. Again, IM or sub-Q injection every 3 months, typically every 11 to 13 weeks. We now know that you can go to 13 weeks, possibly to 15 weeks with this method. It inhibits ovulation, perfect to use, really effective. The main driver of the failure rate for this is just not coming in to get your shot on time. And then typical use, about 3%, again, because of if people don't show back up. This is a category 4 for breast cancer, and then category 3 if you've got cardiovascular disease. Migraines with aura at any age, it's category 2 to start, so it's safe to start, but if they have it, if they're on it and they're having this still, because for some patients it actually improves their migraine profile, it's a category 3 to continue, so you should probably take it off if they're still having pretty significant migraines and they've been on Depo-Provera. Some of the non-contraceptive benefits, again, decreasing ovulation pain, mood changes, some of these other things, PID, and then reducing the frequency of sickle cell crisis. So some of our hematology patients will come in and use this, or sometimes the implant now, and we're kind of seeing that. All right, so side effects, the unpredictable bleeding or spotting. We expect that. That's again the main thing. It's the #1 reason for the injection, for the Medroxyprogesterone acetate injection, or for the Etonogestrel implant. It's the number one reason patients ask to stop the method, or that we end up stopping the method. So after a year, 40 to 50% have amenorrhea. About a quarter discontinue because of those menstrual issues. Alopecia, so sometimes this seems like, is it telogen effluvium? So after pregnancy, you sort of shift everybody into everybody being your hair, all your hair into kind of a growing phase, and then everything's in resting phase, and then it all starts sort of falling out. But people typically don't go bald or look bald with that in pregnancy, in the context of pregnancy. It seems to be something similar, but some people on this progestin will have what looks like true alopecia and hair loss. I've only seen it maybe once, and then weight gain. So we always talk about this. Studies are variable on this in terms of weight gain, but we know that depo for some people can be detrimental metabolically, particularly if they're overweight or had an increased weight to begin with. So I'm always following their weight. If they're having significant weight gain, we have to stop the method, and I tell them that before we start the method and switch them to something else. And then remembering that there's a black box warning around bone mineral density. Again, that bone mineral density returns to normal, improves after discontinuation of the method, but getting adequate vitamin D and calcium and participating in weight-bearing activities. So again, the irregular bleeding, the weight gain, those are the most common side effects and the most common reasons for discontinuing use. So making sure that you counsel on all those issues. And this is some of the data on the bone mineral density. All right, and here's some of the stuff on weight gain. So Angela decides she wants to start the injection, so when do you give it? So for almost all of these methods, the right answer, the best possible answer to this question is that day. If you have the method available in the clinic, whether it's an implant or IUD, whether it's pills, patch, the ring, you can prescribe it, or if you have them in your office, particularly Title X clinics will have them. You want to start it that day in clinic, unless there's a significant contraindication. What we're trying to get away from is what we used to do, and I did in fellowship, which was, okay, I've counseled you on it. The last time you had sex was 10 days ago, and you used a condom, and your pregnancy test is negative. All right, so we're going to counsel you, and then why don't you come back in 4 days so we can validate that pregnancy test and make sure, and don't have sex. And then either they don't come back, or they come back, and I say, or I might say, I used to say, like, okay, we did a pregnancy test today, but we can't be sure, so we're going to have you come back in 2 weeks. And then don't have sex for 2 weeks, and then come back and we'll do another pregnancy test. And they have sex that morning. They tell me they had sex that day. And they said, well, you told me 2 weeks. And I'm like, yeah, but I didn't mean like exactly, or maybe it was like 15 days later or whatever. Or they come back pregnant, which is the thing that you're trying to avoid. So trying to start the methods that day, making sure they have a negative UPT then, and you can be reasonably certain that they're not pregnant. They use condoms for at least that first week minimum, and they understand the risks and benefits of the method when protected. For depo, when we do this, we just bring them back in like 2 to 3 weeks after initiating the method and repeat a pregnancy test then. You're not going to negatively impact the pregnancy by giving depo. I mean, they are pregnant, there's no reason to give it, right? But if you're reasonably certain, but you're like, I just bring them back after they've started the method and repeat a pregnancy test, because I don't want to wait, because of the menstrual irregularity and that sort of stuff. If you waited, it would be weeks and weeks and weeks and months before you figure it out, so I don't want to put a patient in that situation. But using condoms again for the first week, and then understand risks and benefits, and getting EC. I try and prescribe EC when I prescribe contraception. Reason to do this, quick start or same day start, patients are more likely to start. Much more likely to start. Improves continuation rates, offers earlier protection from pregnancy, and there's no difference in bleeding patterns compared to the quote Menses start. Who has prescribed contraception and told the patient to start it the next Sunday, the first Sunday after the next period? Anybody? Yeah. Why do we do that? It's easier to remember the day. We used to do that because thinking, it's like, for me, it's like retrospective, like logic, looking back and saying, why did we tell patients and counsel patients on this? Well, it was because if you started that first Sunday, now it depends on when your period started. If it started on Monday, this may not hold true, or if it started on Sunday and they wait till the next Sunday. But if you started a method, particularly a hormonal method, on that first Sunday, then you're reasonably certain that by the time they would typically ovulate in that next cycle, you would be suppressing ovulation with that method of contraception. So you were the contraception was going to be effective after starting it. But you're waiting to start it. So you're basically giving them this extended period of no method or ineffectiveness to make sure that if they start the method, which they're less likely to start, that it's as effective as it can be when they start it. So that doesn't make sense. The other reason, why Sunday? So that's a dude thing, right? You got to remember, dudes made these medications. They developed these things in the 30s, 40s, 50s. And the idea was that women didn't want to have their periods on the weekends. They wanted to have it during the week. So if you start it on a Sunday, your chance when you go to that pill-free interval of starting your period, the likelihood of having the period on the weekend is reduced, because on average on pills, your period's going to last about 4 to 5 days for most people, not everybody. But most of my patients would rather have their period on the weekend when they're at home and not at school. So at least 2 days of that. I think there's a lot of reasons that I did that for many years in my career until we sort of evolved our thinking on this. But yeah, you got to remember, dudes. Why do you have a pill-free interval on this? Does anybody know that? There's a Catholic, I think he lived in Louisiana, guy that made this happen. So the reason you have a pill-free interval on pills, and it's not really a period, right? You're just providing enough estrogen to have some endometrial buildup, and you're taking it away and they're having shedding, but that's not a period. We call it that sometimes, but it's not really. It was because the hope was the Pope was going to accept those methods as working with Catholicism and say it's okay to use them because you're still having a period. Pope still said no. And we still have these pill-free intervals. And the bleeding, that's really not necessary, which is why we can do continuous cycling. All right, so you want to insert these methods anytime, and then we're going to skip this. We want to take that relevant medical history, explore circumstances for the method choice and compliance, discuss those side effects candidly, be really upfront about that, and make a plan for addressing them, and then encourage dual use, and then write advanced prescriptions for EC. All right, done. Talking fast. Anybody, if we have time, if you guys have time, I'm happy to take any questions. Go back to the beginning part where we had all these other questions, and there's a bunch of resources here at the end of this as well. Thanks. Oh, and if you didn't do your evals, please do your evals so I can take those back.